Assalamualaikum and good evening. My name is Muhammad Akmal bin Mustafa, undergraduate student at RUM for Bachelor of Medical and Health Science. Today, I'll present about the management care of patients with postpartum depression. Let us begin. Postpartum depression is a mood disorder that commences after giving birth. The fifth edition of the Diagnostic and Statistical Manual of Mental Disorder (DSM-5) does not consider postpartum depression as a separate disorder, but rather a type of mood disorder categorized by a major depressive episode. It can occur anytime within the first year after childbirth. However, it usually occurs within the first couple of weeks. Many suffer for up to 6 months, and about one quarter of sufferers still experience symptoms after a year if left untreated. The etiology are divided into two, which are biology and stress. As for biology, post-pregnancy there will be sudden change in hormone level that can lead to postpartum depression. Next point is when the mother consumes a poor diet. Lack of efficient sleep also can contribute to postpartum depression. Post-labor pain is also another factor of postpartum depression. As for stress, it becomes the etiology as sudden change in lifestyle for new mother can cause postpartum depression. Change in level of marital support also suggests why mother suffer from postpartum depression. Having to live up to societal expectation of the happy mother also contribute to postpartum depression. As for the risk factor of postpartum depression are women with a previous history of depression or anxiety, stressful event during pregnancy, premature or complicated birth, women with previous history of PPD 55%, women with illness such as diabetes 15% more likely, thyroiditis 33% more likely. As postpartum psychiatric disorder, they are divided into three: postpartum blue, aka baby blue, postpartum blue, postpartum depression, postpartum psychosis. As for postpartum blue, aka baby blue, the incidents are 70 to 80% and occur within the first week to 14 days. The clinical features are tearfulness, anxiety, insomnia, and mood instability. For postpartum depression, incidence is 10%, happen within first month, and the clinical features are depression, guilt, anxiety, fear of harm to baby, and obsession. Next, for postpartum psychosis, the incidence are 0.1 to 0.2%. Time course within the first month, and the clinical features are disorientation, confusion, delusion, hallucination, and rapid mood cycling. The symptom of postpartum depression. As the depression will likely have the following symptom: depression, inability to sleep, when the baby sleep, intrusive thought, thought of hurting the baby, thought of hurting self, suicidal thought, loss of appetite, lack of interest in the baby, anxiety and panic attack. As a detection of postpartum depression, to detect the postpartum depression, we will screen patient with the following tool. First, Edinburgh Postnatal Depression Scale can be used during pregnancy. Postpartum. It has 10 times self-administered, easy to score, validated in at least 12 languages. PHQ-9. Clinical interview with patient or family significant other. Ask about appetite, sleep, daily self-care, mood, suicide thought. It lasting more than 2 weeks. Now, I'll present my case. As for today, I'll present about Miss N. Miss N was brought to family medicine clinic as she is not eating well and having difficulty to take care of her 3-month-old baby due to mood swing. Her husband brought her after she was angry with him and left the house and the baby. Moving on to her demographic data. Miss N is a Malay woman who has been married for 7 years. It was a pre-arranged union. She is 28 years old, which indicates that she married late in her culture. Her husband, Mr. N, is a year her senior and has lived and worked as a London transport bus driver in the UK for the past 8 years. He's been striving to establish a home in the UK, and it's always the plan for Miss N to join him once conditions were stable. Miss N had been living in Malaysia with her in-laws until last year when she was granted permission to enter the UK and join her husband. She had a rough time living with her husband's family for 7 years. Miss S, her mother-in-law, was domineering and dictatorial, and she had hard time dealing with her baby. Mrs. S believed it was her responsibility to form and mold her daughter in life law and manners to fit her social position. Her health assessment revealed Miss N's pregnancy was relative and eventful, and she was into labor room normally. Routine post-delivery midwife checks were normal, but the health visitors saw that Miss N was becoming increasingly distant set and unable to cope with the new baby around the 3-month marks. This was difficult to assess because Miss N struggled to express herself and was hesitant to involve healthcare professionals in what she perceived to be her problem. When she arrived at primary care, she was assessed with a Hooley question and diagnosed as mild postpartum depression using the DSM-5 criteria and Edinburgh's postnatal depression scale. She was then treated with antidepressant, SSRIs, low level in breast milk, paroxetine Paxil, sertraline Zoloft, citalopram Celexa. As for the treatment continued, she was also suggested to go for therapies such as cognitive behavior therapy, effective in targeting negative thought, teach us about automatic thought, common cognitive distortion, assumption and belief. As for the skill, examining and challenging cognitive distortion, thought record, cost benefits, analysis, asking for the things that are important to me. As self-help support are also provided for those who are needed, they can simply visit this link. For self-help support, Depression After Delivery National Foundation that provides support and information for PPD, we can visit the http www.depression-and-after-delivery.com. For postpartum progress, the most widely read US-based blog, http postpartum progress typepad.com weblog, and Marcy Societies. Now, the major issue in PPD. The major concerns for PPD are loss of autonomy, a personal freedom, like and times, loss of sexuality, femininity, appearance, loss of vocational identity, debate whether or not to go back to work or to stay at home with the child. Many have feeling of guilt. The women have feeling of loss concerning loss of power, loss of opportunity, loss of relationship with partner and friends, loss of finances. To conclude this presentation, based on Mrs. N, we must agree on cultural implication of postpartum depression. Independence risk factor for the onset postpartum depression. Management of patient care for patients with postpartum depression must involve spouse as the spouse is the main support system for the new mothers. With that, thank you.